Welcome. It's nice to have many of you here today. My name is Jim Malatras. I'm the president of the Rockefeller Institute of Government. We just wanted to show a short little video about some of the things that we're working on, and pretty soon we'll have the panelists of experts introduce themselves. But we are holding the first of a series of forums to try to get at solutions finally of the opioid crisis. I think the video describes it the best. We call it the spaghetti solutions problem. Right now, we're literally throwing every idea at a wall and seeing what's sticking. But the crazy fact is, the more policymakers are doing, the worse the problem's actually getting. So there's a disconnect between what's going on in the policymaking community and what's going on the ground. And we have communities that are literally in crisis. So we wanted to bring together experts and start going through issues and solutions to what could actually work in this field. I just want to briefly mention we have two of our main researchers and their team who are working on the ground in Sullivan County, one of the counties, rural counties in the state of New York. It's the size of Rhode Island, but with a significant opioid crisis like many of our other counties. Patty Strzok and Katie Zuber, who's in the back, who's been leading a research team now for several months. And they've really been finding, they call it research in real time. We don't know how it ends, but we're telling the story as it's happening. So I'd like to thank them and give them a round of applause for all the work they're doing at the Rockefeller Institute. And because you want to bring someone in who could really get the dialogue going, we have Liz Benjamin here today from Spectrum. You all know Liz Benjamin. She is the host of Capital Tonight, longtime Albany person who knows policy, gets politics, and can really get at the heart of some of the questions and answers and solutions. So with that, I'd like to turn it over to Liz to lead a moderated discussion. Thank you very much.
Thanks, Jim. So we're going to get started just with a quick round of introductions, and John, you get to do the honors because you're standing closest to me, or sitting closest to me, rather, if you want to go ahead and just sort of lay out who you are and your expertise and your background, please.
Great. Good afternoon. My name is John Coppola. I'm the executive director for the New York Association of Alcoholism and Substance Abuse Providers. We represent the treatment prevention and recovery support community across New York State. And my concern really, and the reason for being here, is really that the entire continuum of services in New York State really should be considering this opioid epidemic and what we can do about it, but I'm also concerned about recent increases in production of cocaine and methamphetamine, and it's really fundamentally about a pandemic of addiction, and it really drives home how important this discussion is about opioids. It's a much bigger picture.
Good afternoon. My name is Luke Nasta. I'm the CEO of Camelot of Staten Island. I think you all have heard about Staten Island. National Geographic called it Heroin Island because of the high ratio of deaths from overdoses in relation to the total population, which is under 500,000. Camelot provides residential treatment services, that is long-term residential, 6 months at a minimum, 6, 9, 12, and then outpatient upon completion of those residential services. We have a 45-bed residence, a 25-bed residence, both for males. We're in the process of building a 35-bed residence reintegration program that is post-residential treatment rather than right into the community when there is a chance of relapse. We'll move them into a reintegration wherein they'll have more time to be monitored while they establish themselves in the community. And we have ambulatory services, and we're in the process of building Staten Island's first 25-bed intensive treatment program for women. My background is I've been at Camelot since 1976. That's my 42nd year. And personally, I'm a survivor of the first heroin epidemic that left the poverty areas and hit middle America. I'm a freak. My contemporaries are dead.
Hi, my name is Avraham Schick. I run the network of outpatient OSS licensed facilities in New York City. We're in the thick of things in Staten Island as well. With the opioid epidemic in Staten Island, we have an outpatient program called Silver Lake Behavioral Health. We're doing a number of things. Part of me is a little uncomfortable identifying myself as a treatment provider in Staten Island when you consider the statistics and how little of an impact we seem to be having. I like to think that Luke and I are having an impact in certain ways, but it's just that it's overwhelming. The problems are overwhelming. So this opportunity and continuing these sorts of opportunities is a real, I think we're going to take this and use this to sort of learn, not just to share what we know, but hopefully take some things back with us.
Good afternoon. First of all, thank you for the invitation. My name is Craig Apple. I'm the Albany County Sheriff. Been involved in law enforcement for a little over 30 years. I don't know if I fall in the expert category, but I can tell you that we've been in the trenches battling this epidemic from day one. And we're doing things a little differently in Albany County, at least in the Sheriff's Office. Instead of just having law enforcement, we've actually got a treatment facility. And we're really big on the prevention and awareness out in the community, and hopefully we'll get a chance to talk about it in a little bit.
Good afternoon. Thank you for asking me and others to be here today. My name is Gay Hartigan, and I'm the owner of Arms Acres and Conifer Park. Some of you may know Conifer Park because it's an upstate facility that has an inpatient detox and rehab. And we have, I think it's 6 outpatient clinics throughout upstate New York, every major city except Buffalo, currently. And in those clinics, which have been around for a very long time in every one of those cities, we now have put in an OTP methadone clinic in Syracuse, in Plattsburgh, in Schenectady, and in Troy. Arms Acres is an inpatient facility in Carmel, New York, which is Putnam County. And we have 3 outpatient clinics downstate. One is in the town of Carmel, which is in Putnam County, and has an OTP in that clinic as well. And we have a clinic in the Bronx and Queens. It is a little unfair to be the only woman up here because, let me be very clear, the drug addiction certainly strikes every gender, every race, every religion. And in fact, I would go on to say that for women, it is a much more difficult disease to treat, as you might expect, especially if they have children, because there are very few facilities in the state that take women with children. I think that the epidemic, as we were all talking earlier, is beyond what you read. And having been in the field for a very long time, I can't, and I think Luke and I discussed this earlier, I don't remember the heroin epidemic before or the cocaine epidemic before having the effect that this has had, because I think it is partly due to the types of drugs that we brought in and that are being constantly created almost on a weekly basis, so that it's almost impossible to actually test what a patient arrives using. That's how amazing this epidemic is. So we'll talk more about what we've been doing and what we hopefully can do. Thank you.
Good afternoon. My name is Jesse Chapman, and I am the peer engagement specialist and certified recovery peer advocate for Rensselaer County Mental Health. I'm a little bit different. I'm kind of like the boots on the ground. I do a lot of outreach and engagement with people who otherwise would have been lost to the system or might not have even known they existed at all. So I help a lot of people get access to treatment. And I also help people get access to the type of treatment that they want and that they think will be effective for them. I'm a person in sustained recovery. So I'm so grateful to be able to sit here today because I am a survivor of this epidemic. And, I'm very passionate about what I do. I really get the opportunity to help other people and to identify with those feelings and those fears. And, it can be really hard for someone to reach out for help. A lot of judgment. I think there's a lot of stigma. So I really work with them to help them accomplish their goals. I'm new to working in the field. I just started last fall. Already I've served over 200 individuals. I've helped over 100 of those get access to treatment.
Great.
Which is just amazing to me. I mean, these are the people that I have so many stories I could tell about the amazing individuals that I have had the pleasure to work with. But yeah, it's an amazing position. I really believe in it. I really believe in the power of peers. There's something about that. I've been through this exact same thing. You know, I've been homeless, I've been incarcerated, I've kind of been through all of it, and I identify with all the feelings that go along with that. And I help them to get in the right place and, you know, work their way out of it like I was able to do.
That's awesome.
Thank you.
Thank you.
So I'm going to start with something general, which is, and given what the gentleman from Staten Island said, and also actually pretty much what everyone said, I wonder if this question is actually even moot. But we've seen some numbers coming out, particularly of Erie County, that some of the opioid-related deaths have gone down. So I wonder if your expertise and your expectation is that we have peaked. That would be sort of a positive, I guess, or that we could peak, particularly given the possibility that drugs are changing when people are coming in with different things on board, and it's difficult to determine what it is they need to be treated for, and the relapses that people experience as part of their addiction recovery process. Is it possible that we have hit the top of the mountain?
I would say I don't think we're peaked yet. I think that to some extent there's a lot to be said for some of the amazing harm reduction strategies that have been employed, bringing people back from overdose with naloxone, syringe exchange, et cetera. There's been a number of initiatives working at the Department of Health, working with drug users to increase the likelihood that they'll be as healthy as they can be while they're using. So I think that there's been a lot and there's been concentrated efforts in some counties that have resulted in, I think, more activity, saving more lives. But there's really nothing to suggest that the upward trajectory of overdose deaths as a whole is in any way, abated. And so I would anticipate that it might be a year or two or three before we peak if we're not careful.
I think focusing on, which is what has gotten it's the deaths that's gotten the attention. We've been at this for multiple decades, informing government every step of the way, informing government there's a prescription drug. We didn't call it an epidemic at the time. There's a prescription drug problem that's happening that needs attention. It fell on deaf ears. We predicted that, or prophesized that once there was some controls exerted over the prescription drugs, that heroin was coming next, because these folks had been addicted to opioids for 2 decades and they needed an opioid. So government throws money at headlines, and the opioid the overdose deaths is what's drawing the attention. If by chance we get control over the epidemic as it relates to deaths, my fear is it'll go back to the back burner. And the deaths, and mark my words, the deaths are the tip of the iceberg. The tip of the iceberg. 1 in 10 reported overdoses results in a fatality. What about the rest of them? What about our society? How many people in this room know of people, immediate family, extended family, neighborhood, co-workers, that have somebody who is either deeply involved in drugs to the degree that it's altering their health and their life, or they know somebody who's overdosed? I'll stop.
I would also,
Okay.
I would also echo that, Luke, because I think one of the other statistics to keep in mind is, and as everybody up here I'm sure has, and many read as much as I can about learning about this disease and the epidemic, there's only like 3 out of 10 addicts are accessing treatment. So they may not be dying, all of those people, but as Luke said, they're not going away. They're not going to be able to survive long-term. So maybe in that particular county, something went on. I don't know. Maybe there was maybe the mobile van was in Erie County that they've now developed. Maybe there was the open access center that Oasis has done. So maybe there has been an effect that's a positive effect. But I would agree with these two gentlemen. I do not see this subsiding for a few years, at least.
And I was just, at risk of repeating what Luke and Evgeny mentioned, I think the deaths just tell one part of the story. I think that if the efforts are being made and they're obviously successful as far as saving folks from overdose, not connecting those folks to treatment and not making it easy in terms of access to treatment, then it's not going to have that impact that we're looking for.
Okay, so it's interesting that you bring up the iStop program. You're actually kind of referencing the iStop program, which was because I distinctly remember a conversation you and I had, John, when that legislation was going through the pipeline, and you said, but what's missing is expansion on treatment and an expansion of beds, and all this is going to do is drive people to the streets to get illegal drugs to replace the legal drugs that they were accessing, and that's exactly what happened. So unfortunately, you were a prophet of something rather negative. But so clearly, I mean, it's not to put too fine a point on it, we're doing something wrong. We're not right somewhere along the line. You gentlemen have beds, you have peer-to-peer counseling, you've got beds, you've got people getting treatment, you've got providers in your network, and yet more people are still using. They're still picking it up. They're still deciding to try, even though they know the danger. Fentanyl can kill you in one option, right? One use. So what is it? What is the problem? Is treatment not sufficiently accessible? Are people too afraid, or they can't afford it? I mean, what is it that you experience that is the main issue?
In my experience too, there's a real particular moment where you need to, make an impact on individuals. And I'm just one person, and I cover a whole county. I would love to have a team of me. Also, it takes getting people on board, like the hospitals on board. So when someone comes in with an overdose, like have a peer there, talk to them. I've had overdose reversals. That can be a turning point. It's an opportunity. I think we're starting to take it, but we need to take more steps in that direction.
Do you think that there are people who would say that we're being too permissive? That these are the same people who would say safe injection sites are not something that we should try as part of the throwing the spaghetti at the wall metaphor that you used, that once a person gets Narcan once, they shouldn't get Narcan again. They're missing the message, for example.
Well, if that was the case, I wouldn't be sitting here today.
How many times?
You know what I mean? I've had 3 reversals that I can recall vividly. That there might be more that I don't even know Narcan was administered.
I think the question epitomizes a huge problem about addiction, which is that either you accept that this is a neurobiological disease and treat it as a disease, or you think it's something that we can be punitive about and moralistic about and see it only as a behavior. And I think what science has shown, and if you look at the brain scans of addicts, if you look at NIDA's research and many other medical schools' research, what you see is this is a disease. And would you be so punitive about the cardiac patient who continues to smoke and eat incorrectly? Would you be so punitive about the diabetic who doesn't want to take their insulin or uses insulin in a way that allows them to eat sweets or drink? It's all the same. We need a behavioral piece of this, and I know Luke's going to speak up on this topic. We do need to have abstinence as long as possible. We do need to have counseling. We do believe in a 12-step model of recovery. But if you don't believe in the science, then you miss the whole boat with this population. You not only need the Narcan to bring somebody back, but you need MAT. And you need every form of MAT that's out there. And you need to engage patients into that.
That's medically assisted treatment. That's what you mean?
Medically assisted treatment.
Is that what that stands for?
Yeah.
Yes, I'm sorry. Sorry.
Just making sure. Not, I mean, I assume everybody in the room knows, but maybe not.
Good point. Good point. Sorry about that.
That's okay.
It's medication assisted.
Medication.
You know, Jim introduced the panel before he threw it to you as addressing solutions and spaghetti of solutions. I don't know about the spaghetti part, but certainly solutions. There isn't going to be one answer to this. So it's going to be everything that Gay talked about. It's going to be a harm reduction approach. It's going to be about needle exchange. It's going to be about a whole host of stuff that might be controversial to some, might be even controversial to some in the field. But there's not going to be one answer. There can't be one answer. And we're going to have to be open to that.
Go ahead.
You know, everything we do as far as treatment as clinicians, what our staff do on the line, everything that Jesse does, it's about being flexible. It's about being open. It's about being relational being able to relate to the patient, to the person that's using. The only way we can succeed is by being available when they're available, being available in the hospitals, all of that. As a field, as a population, when you talk about population health, that's the only kind of approach that's going to work, which means being open to any kind of solution.
John?
You know, it's interesting in the video when they were sort of capturing the very varied environments just in Sullivan County, and these moderators said something about, sort of tailoring the response to the individual needs of different communities and different folks. And there's so much to be said for that there's so many different pathways to recovery, and there's so many different resources that work for different people. So this concept of individualized treatment, individualized recovery, and to think that communities have to have options. There has to be an array, a smorgasbord of services available in communities and in regions of the state where it's not practical to have a certain kind of program available in every community, but at least regional and accessible. And I think it's not until we say that this is a top public health pandemic, and we're going to try to match the magnitude of the problem with a solution of equal magnitude. And so we haven't gotten there yet, so we haven't really created the options necessary to tailor-make the solutions in communities.
It seems that we haven't gotten there because there's a disconnect between what you're experiencing on the ground and what you see that people need and the people who make the policy and control the finances. So if you say, well, the question's wrong, I recognize that the question is wrong, but I think that the people who are making policy, particularly people who are sort of, and I'm going to call you out, Sheriff, because you haven't said a word, law enforcement, tough on crime related, have this idea, and perhaps you don't share it, but there's certainly pervasive in the law enforcement community, that you can't be soft on these individuals. You can't create a safe injection site because what are you going to do to the neighborhood, even if you're creating that safe injection site where you're co-locating at an existing needle exchange where it's already there, right? So how do you bridge that? There's a chasm there quite clearly, and how do you bridge it?
Let me hit a couple things prior to that. First of all, I agree with what was said earlier, where we're beyond the opioid epidemic. Now we have an addiction epidemic, because actually heroin use is somewhat diminishing locally because crack cocaine is going up, because all the emphasis is on fentanyl and carfentanil and heroin. So they're pushing the crack cocaine again. Hopefully we don't go through the 90s. You're right. I was the same way. I was, hey, lock them up, throw away the key, let's move on to the next one. As I sit here right now, I know my guys are out doing a raid right this second. But about 10 years ago or so, I realized, we've lost that battle. The light kind of came on and said, we need to do things differently. And that's what we try to do. And, we don't go out there and just try to hammer the street level users, but we got to start somewhere and try to work our way up. Listen, there's so many different things that law enforcement are doing. And just to be totally transparent, I am totally against safe injection sites, totally. I am all for harm reduction, minus that component. But I think locally, a lot of the law enforcement, including the city that we're sitting in right now, I think we've all agreed that we need to look at things differently. I think the Arrest Our Way Out of It, that's history. I have a jail today that has 560 people in it out of 1,000 cells. So I'd like to think that a lot of our diversionary programs are working and that we're helping people. And I have a treatment center inside our jail whose statistics are second to none. People are blown away, and I just say, go on in, talk to anybody you want. We've got people out there, but I think I think we needed to create that paradigm, and I think that paradigm consists of us, law enforcement, of helping people and serving people as opposed to arresting people. And why I say that is what I have found, I've become quite educated by going down to that treatment center and watching these guys transform. It's amazing. It's almost truly a miracle. And I know, Father Young, you've seen this for, I don't want to date yourself, but probably 60 years, right? I'm not 60. But I have seen these guys, and that's why when you say peer, I just kind of smile, because I think that's some of the best things going on in there, the peer-to-peer counseling and letting these guys talk their problems out. I had 3 grown men, convicted felons multiple times over, done probably 30 to 40 years apiece of incarcerated time, stand up in front of some people from the governor's office a few weeks ago and talk about how they were sexually abused as a young child, and this was their escape, was to turn to the dark world of drugs as opposed to seek treatment for what the underlying issue was. That takes a lot for a guy inside a correctional facility, the big bad guys, to stand up and do something like that and say something like that. So I believe that most people, including probably every one of you in this room, need support. Everybody needs support at some point in time in their life. Everybody, including myself. And I think we need to be there to support these people, and that's where the breakdown sometimes is, the disconnect, when they get out of treatment or something to that effect and there's nobody out there still to help them. So what do? You go back to what you're good at, right? And that's using drugs and stealing and whatever. So we've kind of changed our entire, methodology of policing, and that's what we try to do. We try to serve, try to help people. We check on them when we release them from our treatment program into another treatment program. We check on them. If they follow through with everything they're doing, we try to get them jobs. And at that point, I think personal accountability has to come in, and it's time to put your big boy pants on and get out there and do things on your own as well.
If in fact we are in, I don't want to deviate too far away from the opioid focus, but if in fact we are in an addiction, writ large, an addiction crisis, and not contained merely to opioids, which is the topic of the discussion, do you believe that full legalization of marijuana is going to be an assistance or something that's
Liz, I am so torn on this topic. Here's the issue. I hate to see young kids out there getting UPMs, wrecking their chance for financial aid and college and everything else. It breaks my heart to see that, and that's been done for tens of thousands of New Yorkers. But at the same time, I do firmly believe that marijuana is a gateway drug. I've seen it. I've been dealing with it over half of my life. So, legalization, just to throw it right out there, I think it still needs some crafting. There's a lot of unanswered questions in there regarding, what do we do about, kids are going to think that they can just drive around and smoke now, and you've got DWAI issues, and you've got possession issues, and smoking marijuana in public, and things like that. I mean, there's a lot of changes that need to, be addressed or talked about at least. So I have issues with it, but at the same time, I really am sick and tired of seeing all these young kids have their lives thrown away by the time they're 17 or 18 because they got caught with a bag of weed. Maybe it was felony weight. So,
John, when what the sheriff is talking about, I mean, first of all, it's very time consuming. The process, you're checking on people after they get out. You're checking on people if they leave a facility. Quite clearly, they need continued support in the community. If they relapse, they're probably going to relapse. The process of addiction treatment is a lifelong road. What does the government need to do that it's not doing? It's throwing a lot of money at this problem.
Well,
No, it's not.
I think that it's not throwing a lot of money at the problem. I think that there's really been a failure, and I would say that this dates back decades, that when you have a state budget crisis and you gut the prevention infrastructure in the state, and frankly, when the federal government walked away from prevention a number of years ago when they eliminated safe and drug-free schools, you significantly eroded an infrastructure that begins to try to focus people at all ages on the life spectrum on healthy behavior, healthy choices, et cetera, right? So that's a factor that's not often talked about. So how do we have today a third fewer prevention counselors and prevention people in schools in New York City, and a third fewer prevention professionals in community prevention programs across the state? And then if you look at the treatment programs across the state, most of them have barely had their funding keep pace with inflation. And if you say, okay, well, so how did they survive when we know that we moved from fee-for-service to managed care and everybody had to purchase new billing equipment, billing software, hire billing people, managed care had to start hiring case managers. Well, positions were cannibalized. So counselors who moved from one program to another, the administrators didn't fill that counseling position. And so we have some real capacity issues, and we have a workforce crisis right now where we're not able to recruit and retain staff. So there are beds in this state that are empty. If you go to the OASIS website and say, I want a treatment bed, you might find 15 treatment beds in a program, but they're all going to stay empty because that program will not take any additional patients because they don't have the staff to provide the treatment.
So when people are saying that they, and we hear many stories of people who say, I tried to find a bed for my son, my husband, my wife, myself, and I couldn't. I was turned away. I was told I had to wait. The problem is staffing. The problem is insurance.
Go ahead.
Go ahead. No, you want me to?
Go ahead.
I think there's a multiple of problems. I think staffing labor right now for everybody in this industry we're just swamped. We cannot find counselors. And because of some of the regulations, federal regulations on Suboxone, on methadone maintenance, it's very difficult to find physicians, PAs, nurse practitioners, et cetera, and which the federal issue is a whole other ballgame that makes this 100 times worse to treat. I mean, if you think about it, we're worried about the doc down the block who's giving everybody oxys, and we hold doctors who have the treatment ability to give Suboxone to a cap. And we hold them accountable. Our methadone clinics, they might as well be Fort Knox. The amount of security and everything else you have to have. And one of the other issues, not a money issue, is NIMBY. NIMBY is still alive and well in New York State.
Not my backyard.
Absolutely. You want to put up an OTP, and it will go unnamed, the city that this happened to me in. You will have many people who will come out and say, absolutely not in this city, even though there's an overdose death, even though there's an epidemic going on. So what can the legislature do about that? The zoning issues are key, okay? But I also think there's an insurance issue. I think the legislature has done a phenomenal job in New York State in terms of making the changes they made, eliminating pre-authorization, the 14 days in a rehab. But is it enough? No, because it doesn't totally control commercial insurance. And is 14 days enough? You know, I mean, some of us would argue it's never enough. Nothing's ever enough, you know. But I think there's more to do with insurance. Insurance isn't as open to paying for some kinds of MAT. So there's a multiple of issues that affect access and affect our ability to treat people.
My door is open. If I'm funded for 45 beds in a residence and there's a need for 48, I'll find a cot somewhere. And Camelot's not for profit. It operates off governmental grants and also fee-for-service. We're long-term. I'll make it work. Now, and I don't know if this relates to your operation, Gay. If you don't have insurance, you get turned away from the 38-day miracle programs, which you can't cure heroin addiction, opioid addiction in 30 days, or 60 days or 90 days. It can't be done. Yet that's the model. So one of the major problems is we're following a medical model to solve this, and MAT, the medication-assisted treatment, is called the gold standard. I keep doing this. It's called the gold standard, and I think we're going down the wrong road. Why are we going down the wrong road? Because the doctors, the pharmaceutical industry, brought us here. They're going to bring us out? I don't think so. We're relying on traditional methods to solve the problem that never worked.
So is there medical treatment available in your facility?
Oh, sure, we have medical staff, but they're under my supervision. They're not running the program.
Are you using Suboxone?
Oh, sure. Yeah. If psychotropic medication, if a person has mental illness, and just about everybody probably in this room could get diagnosed with some form of, we attend to that, and we've taken patients who are on methadone, and years ago we had a fight with the state about a person who was on a methadone program that the state was paying for, that we would provide outpatient services because the person came to us and wanted outpatient services, because in a methadone program, the counselor to client ratio is 1 counselor to 50 patients. Some of the most complex patients that a doctor will ever see. As a matter of fact, doctors don't want to deal with them because they don't want to deal with failure.
So in your mind, because we're following this standard of that is wrong,
The gold standard, yeah.
where should we be going instead?
Well, as is stated, there's no silver bullet. There's no one way of doing it. I mean, I have, I need to defend counseling treatment. And frankly, I think morality comes into play. I think judgment comes into play. I think it's important that we say this is good and this is bad. This is right and this is wrong. Instead of, nah, everything's cool, just don't hurt anybody else. Everything isn't cool.
Does that work for you?
I think I see this a lot in even in the recovery community as a whole. A lot of times people protect the things that worked for them, and they're not really open to everything else. I think it's one of the main issues. I think in the recovery community, if we could come together, we have a lot more in common than we have differences.
What are you hearing me say?
I'm just
curious.
saying in general, when it comes to,
I know, but what of my comments are provoking you well, not provoking you, but
no, just I'm just paying attention to the way that we seem to get preoccupied with, this is the gold standard, and I agree with you 100%. I don't think there is any silver bullet, and I think everybody wants there to be one.
Okay.
And instead, we just have to really focus on all these things. Different things are effective. I went through treatment in the past, and I failed. Law enforcement is what saved me in the end through a drug court. But that was my path. That's not going to be everyone's path. Everyone has a very different path of recovery, and I just feel like there's a need for everything. And sometimes I think that just the recovery community, it criticizes everyone else so much instead of coming together.
What's missing the most from your experience?
I mean, that's a difficult question. I think what we're really missing is, this idea that there is no silver bullet and that everything is needed. And I think that we need to equally contribute, funding to different things that are going to work for different people.
Right.
It's hard to pinpoint one thing that's missing. I think, we need more beds. I hate that a lot of inpatient detoxes are kind of fading away, but I also see the need for the outpatient detoxes. So it's just it's a situation where I see all of it as important.
I would supplement what you just said, and I'm thinking again about the whole Sullivan County experience, right? So if you had a range of possibilities for people, so that when one thing doesn't work, you can try another, or you can try the first thing a second time and a third time and a fourth time if you need to, right? And that there'd be a sort of regional collaboration that existed, the kind of relationship building that's necessary to accomplish the world that you just described, I think is a significant investment in time that has to be made. It can't be a debate about MAT or no MAT. It can't be a debate about harm reduction or no harm reduction. It's about, in some cases, saving lives, in other cases, helping people to be as healthy as they possibly can. Given, Luke's point about right and wrong, some people make choices that aren't healthy. And so what is our moral obligation to those people? And how do we provide support to those people who might not be doing the best things for themselves at this time? So I think the kind of dialogue and really a comprehensive approach that's not an either or is really critical.
Jesse mentioned in his when he presented himself and talked about finding bias in the field, and still finding a lot of bias out there. To Jesse's point, to his most recent point about the recovery community coming together about there being no silver bullet, about any solution potentially working and so forth. That's the critical piece to eliminating, or at least diminishing to the best that we can, that sort of bias. If there is, as John mentioned, this one type of thing versus another, then as a field, as a recovery community, we're essentially building, and we're more fully developing that bias, because then we're not on the same page as far as what sort of treatment might work. It's not about what sort of treatment might work, it's that any treatment will work. And if we don't have that approach, then we can't expect anybody else to accept what we do, or to accept the substance user and allow them to access whatever it is that they need.
I do have one more question. I do want to open it up for questions from the audience. But what is it that needs to be done that's not being done in order to convince the legislature that more needs to be done? I mean, I remember a number, John, I hate to keep coming back to you, but you were the last person I interviewed about this in any extended way. There was a number. You had a number you were seeking in the budget, and you didn't get it, if I remember correctly, right? So. And, some of it has to do with the law enforcement piece, the tough on crime piece that we were speaking to, and this idea of not accepting that there needs to be a range of possibility, that there needs to be one possibility, over-focus on overdose. We should give everybody Narcan. We should put it in schools. We should put it in libraries. We should give it to EMTs, et cetera, and not focusing enough on preventing people from starting in the first place, for example. So what is it that needs to be done to convince the legislature, first of all, to remain focused on this issue, because they flit around all over the place, right? And the danger is they'll put it on the back burner and forget about it. The federal government, I'm not so sure right now that you can influence. So, and of course, then if there's an overhaul of healthcare, that's going to be a problem as well. But specifically, what do you need to do to convince the legislature, or how it's failed up until this point to get everything you looked for?
I think, one of the leading factors is really just grassroots people in communities. The Times Union survey said that 80% of respondents from the community and an equal number of stakeholders, 80% said the government's not doing enough. That seems to me to be a pretty compelling argument. And over 50% said they've personally been impacted by somebody who had died. So I think that the increased and the pain and the agony of families that have lost loved ones, I think, is compelling a lot of people into advocacy efforts. And so I think grassroots is really important. And I think at the other end of the continuum, the leadership of the governor, the speaker, the majority leader, those three people and anybody else that's at a leadership position has to be able to kind of get in a room and figure out, how do we make a commitment, and not without accountability and not with just random, dumping money, but there's a lot of really good things that have been done, but fundamentally support the programs that have been in the community that have really been dying on the vine. There's programs that have closed in Sullivan County and elsewhere, and they've closed, frankly, because of the economic hardship. They just haven't been able to keep themselves open, or they haven't been able to hire the staff they need in order to do a good job, and the state came in and said, we can't have you continuing to do this work at this level. And so it's a combination of things. One thing I think is really important.
Let me just jump right there.
Yeah.
And when we go to the government, state government, and say that we're neighborhood providers, nobody knows our neighborhoods better than us. We have our thumb on the pulse in the neighborhood. If we don't get what we need in terms of infrastructure to continue that operation, we're going to fold. First of all, this is the response. Literally, this, and then merge. Merge. Well, now from a business standpoint, I get it. Why pay for 15 administrations when you can pay for one? Except when the monster operations, the assembly line operations, which is how government looks at, well, how do we solve this epidemic? Let's set up massive clinics. It's not going to work. This disease is not going to be cured in an assembly line clinic because every one of us is an individual. And we can generalize about the behavior, the drugs that we're using, etc. But when it comes down to sustained health, then we become individuals. And an assembly line is it's not going to work. It will not work. Go ahead, John. I'm sorry I jumped in.
No, so again, I think it's about supporting. New York has an amazing infrastructure. There's a lot to build on. There's some amazing people working at the state agency at Oasis. I think they've done remarkable things with limited resources. So I do think, and again, I think in the spirit of collaboration across borders, I think a dialogue like this with some of the leadership, just as a concrete example, there was some pushback in the assembly for a number of years where there was some real anger about, well, now that this is a problem impacting Senate districts, where there was a real racial concern about how when it was affecting communities of colors we were locking people up and throwing them away, and now that it's in your communities you want us to throw money at the issue. And it just struck me the other day when I was looking at some of the statistics about overdose deaths. They're very, very high in communities of color. And so I think some of the old dividing lines have to be addressed. And we have to really, again, the same spirit you were talking about earlier, is really look at the totality of the different communities and make sure that we're being innovative solutions that are available to everybody, and that it's in a spirit of public health, not criminal justice.
Do you want to, I'd like to open it up. You have a mic. Awesome. Go for it.
I'd like to say one thing. My name's Greg Spencer. I've worked in the field for about 30 years, okay? And I've heard this over and over and over again, what everybody's discussing today. And we know that there's 3 to 4 factors that are really important that we need to deal with. And one is treatment, one is recovery, one is law enforcement, and you hear very, very little about prevention. If we can stop this, if we can somehow slow things down, then we don't have to worry about treating the individuals. So I think we should be putting much more of an effort into trying personal responsibility, getting parents to talk about the schools. We keep handing it off to somebody else is going to take care of them. Somebody else has got to take care of them. We need a whole process where we all get together and reach out to stop it.
Absolutely.
And the Times Union survey, the top 2 things that they said that people should be investing in where we need more resources were prevention and treatment. Those were the top 2.
My mantra is collaboration is the cure. And what am I talking about? Law enforcement and treatment are the model for collaboration is the cure. Law enforcement and treatment 40 years ago were enemies, because law enforcement looked at it as a bunch of junkies, and the hell with them anyway, it's one less junkie. Well, that's changed. That law enforcement realizes, as the commander said, I believe it's commander?
Sure.
Yeah, okay. As the commander said, we can't arrest our way out of the problem. And so law enforcement, and that includes the drug courts, and law enforcement, the judges, work together with the treatment programs. So there's an element of coercion in there that doesn't cure the person, but introduces the person to treatment. And if we got collaboration from the medical profession, from the pharmaceutical industry, from the insurance industry, from the departments of education, real collaboration, not just here's what we're doing, no, that's what you've been doing. It's not working. Okay, what are you going to do differently in the face of this epidemic that's killing 100,000 people a year? What are you going to do differently? And I'll end, accountability to each other.
Is it moot, because no one's mentioned it, and I guess it would be you, Sheriff, to mention it, is it moot to even talk about stemming the flow of available product?
Can't stop it. I don't want to say we gave that, but I agree with Mr. Spencer. We've taken like a triangle approach. We do the treatment inside the jail. Obviously, law enforcement's out there, but the other tip is the prevention and awareness. And we've taken buses, made them mobile education centers. We've been in every city and town in this county doing forums. Unfortunately, we kind of sometimes preach to the wrong choir because we get the parents that actually care as opposed to the parents we really need in there. So I've even talked to schools about, listen, give the kid 100 on a quiz if his parents show up. Do something, a little unorthodox to get him out there. But I totally believe we need to focus more on prevention and awareness. Look, at the treatment's there. It's always going to be there. We're always going to, unfortunately, have addicts. We've got to continue. We got to chip away at that. And we got to keep these young kids from trying to get to these parties and doing what they think is the cool thing with their peers, and whether it's gummy bears laced with fentanyl or whatever the case may be. But we've got to keep these kids from trying it in order to win this epidemic.
I wanted to bring up two questions that came out of the Sullivan trips. And the one was really striking. Last time we were down there, we had a judge and a doctor both look at us, Katie and me, and say, well, what should we be doing? We're there to learn from them, and they're saying, what is it that we should be doing? We're making decisions. We're sentencing people to drug courts. We're sentencing people to prison. What should we be doing? So one question is, can you just run through the different kind of treatment options, medication-assisted treatment versus abstinence or whatever the treatment options, when they're likely to be effective, who should be looking at them, when should they be put into place to help, doctors and judges and other people who are making these decisions? And the second question is about law enforcement, and we get the question about needle exchanges all the time, but what we hear from moms and from DAs and from law enforcement in Sullivan is that these mothers are asking the sheriff to keep their kids in prison, begging them because this is their last hope for treatment. So I wanted to ask about, and this goes to what Jesse's point too, what is the role of law enforcement in this crisis in terms of, I had one addict tell us that this is the only wraparound services come through parole. So talk about what's the role of law enforcement and criminal justice in the crisis, and also kind of break down for the folks in this audience, what are the different treatment types and when are they more or less likely to be effective and who should be sent to different kinds of treatment?
Listen, if you asked me 10 years ago, do you think you'll ever be doing drug treatment? No, not at all. I would have said you're crazy. But you know what, we had to kind of change with things as well. No offense to my panelists up here, but I run one of the best non-for-profits in the area. And I've got great data. And we don't use methadone, I don't use Suboxone. I have kind of changed my opinion a little bit on methadone. I understand that people need some sort of medically assisted treatment. I get it. I use Vivitrol in the jail, and we're doing a state pilot right now with buprenorphine. And I just think that, listen, we can get through this mess. I have a very good program, but it's a program that works with the Addictions Care Center of Albany, and Oasis has had their fingers in there too. And it's a collaborative effort. We didn't know what we were doing. We had no idea, but we had to do something because I think the state was way behind here. I think they're still behind. And, we talk about money. I'm still waiting to see it. I don't ever see the money. I see everybody stand behind a podium and slam their hand and say we're throwing millions at it, but where is it? We don't know where it is. So we've had to do very unorthodox things, like take clerk typists and teach them how to be a KSAC and go out and look for those that are addicted and take them out and talk to our peers in school and say, listen, I was the captain of the football team, and et cetera. And now look at me, now I'm fighting addiction for the rest of my life. And, we've had to do a lot of different things. I think law enforcement in general has turned the corner where a lot of people realize that we can't just keep throwing cuffs on kids and throwing them in. And we have a lot of services, but again, I have their undivided attention. You're not walking away from my treatment facility. And if you do, we got a problem. But I still stick with what we said at the beginning where, it's a support mechanism. Some people just need somebody a little bit more to lean on. Some people need to be kicked a little harder than the others to get back on that rail. And I'm very proud of our program. I'm very proud to be able to do this for this county and be able to have the results that we've had. And we've taken other people from other jails. And to touch on the comments about moms, breaks my darn heart when I have moms calling me weekly and have for years about locking up their daughter or locking up their son who's sitting in one of the local hotels prostituting himself or herself out for a couple of bags of heroin a day. Or we take a guy off the street who's got 3 girls in 3 rooms and he's doing a sex trafficking and drug trafficking, and just keep feeding their habit. Breaks my heart, but you know what? We'll do that. We'll go in and we'll make a B misdemeanor arrest, and we'll get him in jail, and we'll tell mom or dad it's tough love time. Please do not bail them out, because bail's going to be set. It's usually like $100 or $200. It's tough love time. Just give us some time. I can't fix them overnight, but you give me a month, 2 months, 3 months, and we can change a life. And it's the hardest thing I think a parent could make. I've got 3 boys, and I can't imagine them spending a day in that county jail. But sometimes it's the last resort. I mean, I've got a family that goes down and checks on their son periodically, or used to, down under the bridge. That's one of the most sad things I've ever heard. I've had 6 moms and dads in front of me at one time on a Friday 2 years ago, all from Averill Park, who lost their kids within 30 days. That's unbelievable. So I think parents as well are just like, we've got to do some crazy things here to keep our kids alive. But I also think that parents need to be parents. Parents can't be buddies, can't sit at a dinner table and everybody sit on their phone and have a texting conversation. Parents need to engage, and parents need to break every privacy rule with their kid they have and make sure that they're on the straight and narrow. Because the minute you turn your head, that kid could be fighting this addiction.
I think to take a stab at the other question that you asked, it's kind of what we all have said, which is there is no silver bullet. I think that for many addicts, Luke's idea of self-help and abstinence and a long-term supportive program absolutely works. I think for other addicts, methadone does work, Suboxone works, Vivitrol is a great medicine and is used now in more jails, so that many people are getting their first shot of Vivitrol while they're in the jail, and they're then brought into an outpatient clinic. And if anybody doesn't know what Vivitrol is, it is a shot, which is ironic on itself because there are many addicts who don't want it because it's a shot. But it works to eliminate any craving and any ability to get high. By the way, not just from opiates, but from alcohol. It was originally an alcohol drug or therapy. We're in the treatment programs, we're constantly looking at which medication might work better for which type of person. And I don't think anybody's come up with that answer. I mean, on one hand, I could say to you, if it's a young addict who hasn't had a long period of time using opiates, Vivitrol might be great, because you've got 30-day increments where you know they're sober, they're not going to overdose, and if you keep them in treatment, whether it's a TC or whether it's our treatment or outpatient, they're secure. And so that for a young addict might be the perfect thing to do. But who knows? I mean, you've got to try it. And this is a chronic relapsing disease. These people are going to go back and forth. That's part of the disease, and we all know that. So I think what I would tell that judge and what I would tell that physician is go to a treatment program. I don't care if it's Luke's, ours, go to an outpatient treatment program, see what works. And as somebody said earlier, and maybe it was you, in the jail program that you have, this is all the negatives, but I want to tell you, if you see the person, Jesse's a great example, who their entire life turns around, they're like reborn. It is the most amazing thing to see and hear, and there's nothing greater than that level of peer support and recovery in an AA meeting or an NA meeting. Nothing. So all of that combined is what I think I would tell them to do. And by the way, the parent that comes, and you had a question about that, the parent who's got some kid who's out there, who's been using drugs and alcohol for a long period of time, hook them up with another parent, a parent who has gone through it. And as John said earlier, some of the parents in this state that we all up here know, who've lost their children, who've gone through that horror, they have become the greatest advocates throughout the entire state. They're what really moved the legislature, I believe. It's not unlike MAD. They're the ones who came out, and everybody knows somebody, and no one wants to be in the position of those parents. But that's what I would recommend to a parent. Before they go to treatment, hook up with another parent. They'll help you.
Hi, my name is Stephanie Campbell. I'm the Executive Director for Friends of Recovery New York, and I just want to express my appreciation to the panel. I wanted to just touch on something that hasn't been talked about, and that's the issue of parity. I know that we've been talking about the moralization around this illness, how it's really been treated as a moral deficiency, not as a chronic illness, similar to other illnesses. And I think part of the issue that we need to really address is the issue of parity, so that folks get access to prevention, treatment, and then, of course, the recovery support services that are needed to address this chronic illness.
Hi, I'm a parent of somebody that had died from a heroin overdose. My daughter was not young when she got addicted. She had a 9-year career as a lawyer. She was unemployable for the last 5 years. She was codependent with her husband. She lived in Suffolk County. She grew up in this area, and I have a letter that she wrote that anybody can read if they want to, about her addiction. She wrote it in rehab. She journaled a lot about it. And, I also have a nephew. His father was with the Sheriff's Department in Albany County, and I know you know him. And he's been fighting it for 20 years, but he was 15 years old, and he was 12 years old when his father died, and he went through a rough time. And so I'm that parent that wants to talk to other parents that need help,
Thank you.
because, that's why I'm here today.
Thank you for sharing.
Sorry for your loss.
Hi, I work in the Budget Commission. I used to work for
I have to, okay. And I just want to share an observation and also ask what I hope to be a provocative question of the panelists. So my observation is that there are so many divergent voices on this issue that we're struggling to come together on the consensus that prevention really is the key here. Assuming that the prevention, the treatment modalities still exist and are there, and law enforcement is doing its role. But the consensus on prevention and how to tackle that, and I know, John, you represent an association where you have prevention providers and you have treatment providers, and then amongst the treatment providers you have varying modalities there. My question to you and to the sheriff, who has a standpoint of, I'm law enforcement and this is my role, I have to do something now, I have to react, so I need to pull resources in and I need to get into the treatment business. What are each of you doing to build consensus on the prevention chasm here that we have? What are you doing, Sheriff, to back down off of this stance on syringe exchange or safe injection sites? I can't recall which one you had an issue with, but how about we stop talking about our differences and what we disagree about and start talking, no matter who we are, about where we need to start.
Right.
And how can you become leaders in getting that message clear as day to the policymakers? Because I think that's what Patty Strzok is trying to get at with her team, is what can we say to policymakers who are asking the question? So how can you all come together, and what individually will you be doing to find that consensus and get your messaging straight?
Well, 2 parts to that. A, I will not back off my stance opposing safe injection sites. So I won't even broach that. But regarding prevention, I walk the halls of the Capitol. I've talked to our locals. I've talked to fellas that I know outside, whether it's Assembly or Senate, about having mandates in schools, having state ed get involved and talk to make it mandatory that either 20 minutes a week, we're not asking for the world, we're just asking to save our kids. Whether you can get in there and talk in the classrooms, whether it be health or PE, have some of these mandates, some of these grants that are going out, make it mandated that You know what? You have some sort of prevention issue in there, whether it's summer meals or whatever. We'll go talk anywhere. I've got a bus that we've taken all over this region, out of this state, up north to Tupper Lake, down to Cobleskill, you name it, it's traveled everywhere. And we take peers with us. If we're going to an elementary school and talk to kids about the dangers of drugs, I'll take the youngest, unfortunately, the youngest addict that I can find to go down there and talk to those kids and let them know that, hey, I was you. I mean, we're doing a lot more than just law enforcement. And I apologize for the safe, well, I'm actually not going to apologize for that. I just can't go along with the safe injection sites. I've talked to people, I've got good friends of mine that are huge proponents, and they've tried to, you know, just do about everything but waterboard me to get me to sign off on it, and I just can't do it. I have a real moral and ethical issue being a law enforcement person, walking past the house knowing that there's illicit drugs in there and they're doing things that are, you know, illegal. I just can't turn my head to that. I think there's other harm reduction measures out there that we can do. I also, you know, I still don't think it's going to clean up our parks. I don't think it's going to prevent people from shooting up at the park like they do now, when they know that, you know, I can go down the street and shoot up and be safe 4 blocks from here. When they want to shoot up, they're going to shoot up.
Before we leave this topic, I think that, you know, the problem, there's a lot of disparate voices and a lot of discussion about we have to have access to a wide variety of things because you don't know what's going to work, and each addict is an individual, and each person needs a long period of treatment, and you can't cut them off at 14 days, and you're not going to treat them in 60 or 90 or what have you. And I think that there's a stark reality, which is that, you know, is the situation that state government has a limited amount of resources. You may disagree with how state government is allocating its resources, but the reality is that there's a limited amount of resources. So I think at some point, the question sounds to me like you have to figure out what are your top asks, and so you can all with one voice ask for those things and not be all across the board saying, well, this treatment program needs it because it works for some people, and this treatment program works for other people, and this treatment program works for other people, and we have to have all these things available. I mean, it is true that the legislature capability of focusing, and it is true that lawmakers are asking, what can we do? We hate it. We have constituents coming to us. It's terrible. Yes, there is a certain racial component because it is hitting a higher level of socioeconomic voting areas, and that's making new people concerned. I mean, that's a significant reality. But if you're scattershot and you're asking for the moon, you're not going to get it.
Yeah, so just a thought. You know, when you look at the consequences of untreated addiction, so we have domestic violence, we've got criminal justice offenses, we've got child abuse and neglect, unemployment, homelessness, et cetera. If you look at any approach that we currently have in already expended state resources, and if we said, okay, what we want to do is we want to do a pilot project. We're going to take some of the existing dollars, and this has been done in the past, and we're going to set them aside, and we're going to co-locate, let's say in the case of child abuse and neglect, we're going to co-locate some addiction counselors in the Child Protective Services office. We're going to screen parents, which is not our job. Our job is to protect the kids. We're going to screen parents for addiction. Where the flashing yellow light goes off, we're going to do a more in-depth analysis of their drug use. And if we determine that they have an addiction issue, and if they agree to go into treatment, we will give them some sort of heightened case management kind of thing. And in those cases where that happened, there was a precipitous decrease in in additional calls to the hotline, a precipitous decrease in the use of out-of-home placement, and where out-of-home placement was necessary, it was a lesser amount of time. And so there were actually same-year savings, right? So the whole idea of, you know, we do prevention today and 12 years later, no, it's this year. If we do it this year, we'll spend less money this year on out-of-home placements, et cetera. So there are multiple opportunities to do that. If we look at homelessness and say the idea is to move somebody to supportive housing and then permanent housing, in New York City, New York, when Governor Cuomo started talking about the condition of the homeless shelters, I said, oh my God, this is like the amazing opportunity to collaborate with the treatment community and to pull some of those folks out of the shelters into treatment programs. And where would they go? They would go from there to supportive housing, and from there, 47% wind up in unsubsidized employment or college and in permanent housing, right? Which are better results than are generally achieved by folks who do that for a living. So I do think that this idea of resources, it's not just about business as usual every place else, and we try to, it's really, let's look at the impact that this is having across all these different state agencies. Let's do the kind of collaboration that Luke is talking about, and to the governor's very first State of the State address, where he talked about utilizing our resources better, having more collaboration across systems, and then better outcomes, you'd have like an amazing formula. And that is the correct formula. I think just, so look at the consequences of addiction in other places, address those, but address the addiction, and you could significantly, I think, drive down savings. They're doing it with dish rope. They're doing it with trying to reduce unnecessary hospitalizations. And again, those kinds of investments don't require new money. It requires just creative thinking and some innovation. And then you can go to the spaghetti approach. I mean, because it is going to involve an array of resources for an array of responses. And if we have that ability in communities across the state, many more people will get into treatment than are getting into treatment now.
Liz, I want to ask you something. Maybe I'm making a statement and not really asking you something. You say there are limited resources. Now, this has been the Center for Disease Control, National Drug Control Policy, call it an epidemic. It is accurately, as John calls it, a pandemic. Why aren't we treating it like that? What if, you know, if there's every 4 days there's an overdose death on Staten Island. If that was from gun violence, do you think there'd be a different reaction?
Yeah.
Do you think that they'd be coming up with resources to give everybody bulletproof vests and helmets? But why aren't the resources available? The resources are available. We're the richest nation, technologically advanced, intellectual, technical, that we can't gain control over this and treat those already affected and prevent those from, we can do it if we have the will. What's missing is the will to do it, not the resources. We have the resources. The will isn't there. Now, why isn't the will there? Because elected officials respond to the will of the people. But they're not taking into account that the characteristics of addiction and how it affects the individual and the family, which is deny and resist, deny and resist. There isn't going to be a groundswell of voters clamoring for resources. And that's what moves government. It's either big business or big voter groups. Okay, so where's the big voter group? Who are they? I know who PETA is. They take care of, they look out for animals. Who's the national group that represents what we're here talking about today? Why don't they exist? Again, it's the characteristic of the disease. It's government's responsibility that even though they're not getting that big voter pressure, which, by the way, it probably links us all together in the United States, they've shirked their responsibility to deal with this up until this point. We've got the epidemic, and I disagree that we don't have the resources.
I'm not saying we don't have the resources. I'm saying we have a finite amount of resources.
I disagree with that also.
Well, the state doesn't mint money.
The budget goes up by the billions every year. And the Office of Mental Health gets a $6 billion budget. And the Office of Developmental Disabilities gets a $3 billion budget. And the Office of Alcoholism and Substance Abuse gets a $300 million.
Right.
Well, it's a damn epidemic.
But that's an allocation question, not a resource question. The money's there. I agree that the money's there. It's just not being allocated.
But you also got to look at the mental health portion
Yes.
This is as large a mental health issue than anything else. So, I mean, I think they deserve the money, and I think they're underfunded as far as mental health. I run a correctional facility that's got dozens and dozens, if not hundreds, of individuals suffering from a mental illness. I'm not a mental health facility, I'm a correctional facility, but we had to go out and bring doctors and psychologists and therapists in. But I think mental health is underfunded, and they need to get involved with this because almost every person out there fighting has got a mental health illness.
It's a matter of priorities.
Go ahead, Father.
May I share a little bit, because Luke, you're talking about Staten Island. We had 129 locations in the state, 129 programs statewide. And we went to Staten Island to buy that property right by where the ferry comes in. And I went to the community board. It was NIMBY all the way. I tried, we invested money, we lost money. And we've done that I've done hundreds of planning and zoning board meetings. And I've been beaten by dogs. I've been beaten up in the alley. I've had my car's tires slashed again. There's a lot of sad stories when you're going into Bed-Stuy and Bushwick and Brownsville and East New York. You don't know what you're going to run into in that meeting until you walk outside the door, and then they're out there to get you. So we don't have site selection.
Yeah.
We need site selection. Mental health has site selection. What I feel we need to go back again to Rockefeller, because in the 50s, I grew up with a guy by the name of Harry Albright, Harry Albright was my buddy. We played golf and played tennis and all that stuff. And he then went on to work for Governor Rockefeller as his secretary. And when I was down at Green Street, which was a pretty tough turf at that time, it was exciting. The largest prostitution in the entire United States per capita. How about that? And I was a pastor. But what we did do, I went up to Harry, I said, Harry, I need a systemic kind of answer. I'm running a 200-bed shelter of homeless people. I'd go to court every day. I was court chaplain, and at that time, chaplain to the jail. And I was running around in the jail, and the captain and the judge would say, do you want to go to jail or do you want to go to Father? Do you want to go to jail? 60 people would line up every day. And every day I would run that routine. You want to go to court? You want to go to court? Yeah. Okay. Do you want to go to jail or do you want to go to Father? And therefore I had all of a sudden an enormous amount of people. But Rocky came to my answer. When I was up there, we were sitting and talking with Harry, and Harry said, let's go and have lunch. Okay, come on in. And I did that many times. So we had lunch as Rocky would cut off the crust of the little sandwiches he would have. And he would enjoy the idea of talking about Green Street. Green Street was a talkative topic. And he said, Father, what's going on with this Harlem problem? What is the Harlem drug? I said, I've got it in Green Street. He said, no, you don't know. It's only in Harlem. I said, no, I can show you now. And he took Everhart, the chief of security for him, and he said, let's go with Father. And I brought him down. And he said, these are heroin people. Is that the problem? I said, that's the problem. Now, we didn't have fentanyl at that time. No. It was an easy one. We treated them the same way with detoxing on the floor. We'd make sure that we'd walk around at night, make sure that we had their face down. And so that way we didn't get the trouble of their regurgitating and then choking to death. But it was an easy routine to do. And we then built up, the homeless kind of people were going out and needing a place to stay. And the white people were leaving the community. And in leaving the community, they left their houses and we moved in people. And it was all done on taking their work ethic and making it happen. So there's an answer here. There's a will and a desire for people. Now, what I enjoyed most of all was working in prison for all of those years. And I had 41,000. I founded the program of alcohol and substance abuse treatment in there. And when I retired from prison, from the DOCS organization, I had 41,000 every day in our care, 41,000 inmates. And we did it with what we're talking about, peer kind of, we'd meet the guy at the truck trap and say, hey, bro, what do you need? How can we help you? We wouldn't want to force a person into treatment. We'd try to encourage him by a peer kind of coming in and saying, yo, man, what can I do for you? And I hate to get into the stereotype, but it's that kind of routine when you're at the truck trap every day. And I know that they can get the guy in because they can persuade the guy to come in and do something about the life. You got to make it a pleasant kind of spot to be. And that's what happened. And that program now is in 63 prisons in the state of New York. So the ASAT program now, I think, is making a mistake. They're mandating people to go to treatment. When you mandate a person to go to treatment, they become resistant. So I'll get off my horn here and get out of trouble.
So I might be a bit of an unpopular voice here, but I just want to say that, obviously this is an epidemic that's hitting the entire country, not just New York. And it's my belief that I think that the legislature, as well as the governor's office, continues to do a great deal to get their arms around something that the entire country, possibly the world, is struggling with. There is no one easy answer. I applaud the governor's efforts and the commissioner of health's efforts last week by allowing the use of medical marijuana as an option for a prescribed opiate instead of. I think that's a way to decrease the amount of drugs that actually hit the street, which is part of what we're trying to get at in terms of prevention. I think all of these folks up here are part of the spectrum that treats the epidemic that we have here, but there is no one answer. And as long as people are going to be closed-minded to how somebody reaches their recovery, whatever that road may be, we are going to be part of that problem. Every option, all hands on deck, everything must be made available to every family and every addict out there in hopes of getting them to the point of recovery. And I really believe that the legislature has done a ton around this. Their opioid task force in both houses, they've been up and down the state, they've talked to families, they've talked to law enforcement, they've passed legislation. Is it everything we need? No, it's not. Do we need more insurance coverage for treatment? Absolutely. Do we need to keep thinking creatively about how we can get at this epidemic? Absolutely. But to say that the state is not doing what they need to do, I think is sort of a disservice to our elected officials and certainly to the governor and to the people up here that do the work for the government.
Look, just to add, Lisa, we can't leave, and when we talk about a $300 million budget, then you can't leave OASIS out of that conversation. Because to do the amount, or to allow us to do the amount of work that we're able to do, takes some real creativity and innovation. And that's what we're forced to do.
Hi, I'm Jen Haggerty. I'm the Director of Substance Use Prevention and Recovery Services for Rensselaer County. And I want to thank everybody that's brought up prevention because it's often lost in the conversation and people don't understand it. The 23 years that I've had with the county, when I started, we had 15 prevention educators in every district. Every youth in our county was receiving evidence-based curriculum that has shown to reduce the likelihood of them developing a substance use disorder. I am down to 7 staff in 6 districts. Our budget has not increased in 30 years since we've been up and running. When I did ask for extra funding last year, I was denied. I'm very grateful to receive a grant to hire Jesse, and I could use 3 Jessies to do what he's doing, and I hope he does not burn out and leave me. But so we do have some evidence-based curriculum that has shown that if every young person this is delivered to, K through 12, they are less likely to develop a substance use disorder. But it's my understanding 30% of New York State children and youth receive substance abuse prevention. So we're talking about 70% of our young people who are not getting the skills or education that they need. Right. And I just want to be a really strong component for prevention if I can.
John, you mentioned... You were talking about having, when you were talking about child abuse, then having somebody there, though their job was not to address addiction, to yellow light the parents, if in fact it looked like that existed at one point. Mm-hmm. So this program existed at one point all throughout every single district. Everybody, you had this wide array of people, right? And what concerns me is that the legislature just mandated mental health curriculum for every single public school, which is awesome. I'm not saying that's not good. My concern is that there's clearly a lack of sustained attention, not a lack of attention writ large, but a lack of sustained support for what works. If that works, why are we not funding it? If what you're saying works, what happened to that program? And then we keep adding on layers upon layers upon layers. Now we're going to mandate mental health treatment. That's amazing, but we're not even funding what we used to be funding.
Service. And when we did the first 20 years we did this, we do studies. We had a decrease in gateway drug use among young people. the influence, DWIs with our young people, and the Safe Schools Drug Act was removed by most of the districts. It's not a mandated service. They are shared match to our program, so they could not renew contracts.
But it's almost like we're cutting off our nose to spite our face. We knew that these things worked. We have evidence-based that they worked. And then, it's almost in like raise the age. We mandate certain things, and that's fantastic, but there were programs that were put in place in New York City, for example, that were going to be integral to the success of Raise the Age, and then we defunded that program. So we're not even funding what we know works, but we're asking for more and more and more and more funding. That's my point. Right? Voter pressure. I agree with that.
Still think about that. Addiction is a disease of the brain. And we're not thinking about just the drug. We're talking about addiction in general. I mean, how many alcoholics are there out there that are suffering? I mean, Jesse's getting more and more contact with people who are using other substances that are suffering. And we're also talking about gateway drugs. Our future generation coming up thinking it's okay, to use something that's going to damage their brain. So it's just thinking about addiction in a different way, that we have to address it as a whole, not just the substance.
What you described, I believe, so you just talked about one county, right? And of course, and so that's the same picture in almost every county, in the state, and the same is true of treatment. And Liz, just to add another example, which is confounding, is that in New York City there was a care management program that focused on people with addiction, and they worked with 750 people a year, 750, and they provided care management. These were people who were frequently using the emergency department for detox and other high-cost services. And so these folks were provided with some treatment and some care management to guide them in the direction of services that they needed at the level of care that they needed. New York City saved $10 million a year after expenses, right? $10 million a year. The next year we went and said double the program. Double the amount of money you're spending on the program, and you will save $20 million. And that's precisely what happened 2 or 3 years later when they took us up on it. It took a little while to fight for that. But when we went to managed care, it all got kind of folded into the big picture. And again, to what extent can we keep our eye on the ball? And again, when you, in an age of value-based payment, and what is the value we're getting for the prevention services? If you could say, okay, we have a child who's now participating in after-school activities, decreased level of absenteeism, and a better grade point average. And again, these are all measurable things that can be accomplished. And again, it's just, I think, to Luke's point, if we really have a will to accomplish these things, it requires state government to work a lot harder. It requires different divisions in the division of budget to talk to each other. It requires different state agencies. And again, the whole turf thing comes into play. So again, if we just sliced off little tiny pieces and measured it and said, are we accomplishing what we want to accomplish? And somehow getting past all of this kind of silo turf kind of thing, I think would make a big difference.
But what's frustrating is, people are running around going, it's an epidemic, what should we do? What should we do? We don't know what to do. We're asking the question, what should we do? But with your example, and with your example, and with some of these examples, so many examples, we know what to do. And in fact, we were doing it in some cases, and yet we're not doing it anymore. So why are we not doing it?
Because Liz, it was the easiest place to reduce state government resources, because there'd be the least amount of pushback from the drug-related issues, because it didn't have the advocacy. It didn't have the voter group that was going to make those who make those decisions accountable.
But now it does.
Right. But I think part of it also, though, may be that we weren't as sophisticated, the field wasn't as sophisticated at the time in terms of just collecting the data and being able to demonstrate it in hardcore. We're much more focused on hard data, on scientifically collected data, that sort of thing. So, when we talk about money and funding programs, I come to it from a different perspective, and Gay does as well, in that our programs don't get funding. We're proprietary programs. We're sort of set up differently. So it's a little bit more difficult to talk to this issue, although it is an issue. And that's why I sort of talk about, the creative approaches and being innovative and so forth with the money that we have by being reimbursed for services. But I think that, different from perhaps the rest of the field, we have always had to collect data in order to access those funds, But now it's much more broad-based. John throws out, value-based payments, and we're talking about, the lower hanging fruit and so forth. Without having that data, and we weren't the field at large wasn't sophisticated enough to be able to produce that at a level that folks on the other side of the table would be looking for. So I think that may be part of the problem.
I do have to disagree with you. The research has been available to government. There's tons of it for half a century or more. Government has been negligent in responding to the research because there hasn't been a voter group that's forcing them to look at it and forcing them to respond to it.
Was there one more out there somewhere?
Jesse, I know you put the faces on the individual because they're talking about statistics and all, and it's a serious problem. But when you talk to these individuals, do they tell you what led them into this? And in the treatment programs, are they addressing the issues that if they're going to get treatment when they get out, are these issues going to be able to be coped with or addressed?
Yeah, I think a lot of people, that's what treatment's for. My job is to try to help them get to that point, and then once treatment takes over and they really address a lot of the underlying issues. One of the issues that I see is the aftercare, the recovery services. We have this view that treatment is an event, and it's not. It's a lifelong process, and it needs to continue. And I think we lack a lot of those services, and then we wonder why people are coming back again. I'd like to see more recovery community centers and more stable housing for people. Housing is a huge issue where I am. Huge issue.
Yep.
A lot of people come over to Albany just because we don't have it, and they don't have it here either. So it's just really difficult.
Well, in terms of housing, I'm looking at you because maybe the legislature is addressing the opioid problem, but I don't know that they're addressing the housing problem, and they're not addressing this in a holistic way in terms of the homeless crisis in New York City. What about the homeless crisis upstate, which also exists and per capita in this similarly significant way? And they're, mired in a pissing contest between the governor and the mayor. And that's very frustrating,
You have treatment, housing, and employment, or trading for employment.
Yep.
You have to be a stool, a three-legged stool.
Right.
And I just commend Rockefeller because Rockefeller really, and I thank you for doing it and having it here, because this is great to have a chance to meet all these folk who know more about it than I do. But I'm delighted about the idea because Rocky said to me, "What do you want to do, Father?" We came out of that meeting down in Green Street, and he said, "I'd like to change the law and make it a disease." He said, "Okay, that'll do it. I'll sign the bill in 10 years. Now, here are 10 years you have to do it." We sat there in the office, and we planned. He said, "I'll sign a letter. What do you need first? Housing." And he then gave me the bill for the ATCs. And he gave me the bill, and he said, "Go and create them. Here's the letter authorizing all state facilities to put a program in their facility according to your need." And I walked around like a kid in a candy store. I went around to all the state campuses and said, "I'd like that building over there." And then I got sobering up stations, and I got then one thing after another, then the insurance legislation, then the education legislation, Senator Spino's legislation that you're talking about. All of that is done in time. Now, when we talk about that he said 10 years. I was very upset, but I had over 30,000 meetings in 14 years of my life before I got in to sign it. So it does take time.
I don't think we have time.
That's right, we don't.
We don't have 10 years, I'll tell you that. I don't, is there any, well, let me just say this. So obviously I've covered this issue for a number of years, unfortunately, and I've hosted, this is the second one of these that I've done. We did one at Spectrum based around a documentary that we did, and Jim was kind enough to be there, and the sheriff was kind enough to be there. And, but I don't obviously have, I don't know all of the areas, and some of the places that have been touched on here I was not aware of. Is there any issue that we have not discussed that needs discussing before we deconvene?
Can I just say one thing?
Please, sir.
I think one of the problems that we have One of the problems that we have with the prevention area, there's no money that comes to people. People need information, right? Where do they go to get it? They can't go to the treatment facilities because they can't be billed. I call up as a parent and say, who can I talk to about my son or my daughter or my father or my brother? They've got a problem. And when I call an Oasis treatment facility, where can I go? Well, you can bring them in, and then we can talk to you, but we need to bill the person. We have to have somebody in there with a diagnosis. You don't have a diagnosis. Where do we go to get that information? Well, call your insurance company. Nothing.
Is you able to bill for family services?
Yeah, I just want to correct that. That's actually untrue. Any OASS treatment facility can treat a family member or assess a family member or engage a family member, even if that loved one, the one that's using, is not in treatment. And it doesn't have to be a family, any significant other. They should. We do.
Are there any states or countries that have a demonstrably more effective model than that which we are using?
Not that I know of.
Interesting that you asked that. There's a grant that I understand has just come out from SAMHSA because Vermont put in a hub and spoke system, and the latest research from that is pretty significant in reducing opiate deaths. And now, I think is it 25 million that SAMHSA, do you know? I just saw this, that Oasis is involved in to put that kind of a system in place in New York State. So you'd have this hub and spoke, a outpatient treatment clinic potentially, and then, a network of services. But it's all about what we've all talked about. You need to figure out how to engage people at every level. The parents, the kids, law enforcement, treatment facilities, peers, advocates, the AA, NA community, and that's the network. That's the hub and spoke on some level.
We'll have time for one more question, and we'll just let someone right here that hasn't gone yet. We'll have one more question.
You asked if there were any areas that we hadn't covered, and the sheriff referred to it as a lost cause, and that's interdiction. And at the macro level, I think internationally, we could stand to look at what is coming into the United States. The original heroin addiction in the 60s was effectively stopped by Richard Nixon basically buying off the Turks to get them to stop growing opium. And this particular cocaine influx that we're seeing was known to the federal government at least 3 years ago when the Colombian government made a deal to stop spraying the coca crops in exchange for the drug lords to stop killing government officials. So they knew 3 years ago this was going to happen. And now, of course, and government officials were told at the state level and at the federal level, and they did what about that exactly? Pretty much nothing. So now everybody's saying, we're starting to see cocaine. Well, if you were here in the 90s, you'll know that in a very short while, we're going to start to see crack again. So we know this is coming, and we're doing exactly what? Just as John and Luke and the other substance abuse providers told the government, you're going to have a heroin addiction problem, a really big one, on your hands in about 5 years. And that turned out to be true. The government's known about this. So I don't think we ought to be dismissing interdiction. I think maybe we ought to be doing something about that.
Well, don't get me wrong. I'm not saying we're turning our heads
No, I know
to it,
you're
by no
not.
means.
You're in the trenches, but nobody's listening about that. I don't understand.
No.
And as one more issue.
Fentanyl's coming from China, the heroin's coming in from Afghanistan through Mexico. I mean, but the amount, if I know what's in this area, the amount coming into our harbors has got to be those metal containers just stacked. But I don't understand why we can't get some of this. I don't get it. Yeah.
It's a matter of will. Do we have the will?
And one of the things that's really scary about what you're saying is that the cocoa production right now is at a record level. There's never been more produced than right now. And you absolutely know that the United States will be the epicenter for the use of that. And then also the methamphetamine, like more and more phone calls about methamphetamine and making a sort of a resurgence. So again, we think, and of course, alcohol is always the one thing we don't talk about. So it's.
But we know this is coming.
Yeah.
We know this is coming. The government has known at the federal level, the states have been told, and they're going to do what? Sorry, but everybody who remembers the 90s, crack, if you're a heroin addict, you're going to steal your mother's engagement ring while she's not home and go get your heroin. If you're a crack addict, you're going to bludgeon your grandmother to death for the $20 she has in her pocketbook.
Yeah.
We've been through this before.
Yeah.
So if I know it, why isn't our government doing something about it?
Right.
Because drug abuse has no lobby. Because parents will not come to the high school meetings. They will not come. It has to be mandated. Your kid can't get a parking spot or be on a sports team if you don't come. The parents are not doing their job either. How do you motivate parents? If Dead Kids isn't going to do it, I don't know what is. I'm extremely pessimistic, having seen the heroin addiction of the 60s and 70s and the way it changed life in New York. And now this new addiction that is way worse is going to change our society. I personally think it's not so much as a solution as you're going to slow down and basically change society to accept drug use and the concomitant damage as a part of life. But I'm a pessimist.
Well, we have to end it there. We could literally talk about this for hours. The good thing is this is the first of many. I've promised 10, but we'll do more, and we're going to go across the state. First, thank you to Liz Benjamin for moderating. Let's give her a big round of applause. Also, passions run high, but that means people are really deeply committed to trying to solve a problem, which is what we appreciate. You hear it in the communities all over. And so let's give the panelists a big round of applause for they're working on this so hard. And then finally, we want to thank all of you for coming because you all have, in many cases, an individual stories of dealing with crisis or this issue. So give yourselves a big round of applause.
Jim,
that was like a moderate round of applause for yourselves, by the way, just to let you know.
Jim, before you send everybody off, I just want to say thank you for your leadership and for the work that Rockefeller is doing. You know, the reputation that this organization has and being a part of this conversation and frankly making it the priority that you've made it is going to make, I think, a huge difference. And we really appreciate your collaboration and the good work of your staff.
Thank you. Thank you very much. I didn't actually pay him to say that, but no, seriously, we here are involved in this because this literally is a matter of life and death, right? And I think stories like Jesse are great stories, and we want to tell those stories across the state. We want more Jessies in this world. So let's focus on this. We're here to help and facilitate dialogues, and let's hopefully one day come back and say, we've really got a handle on this. So thank you very much for coming today.